Greetings. My name is Dr. Marvella Ford. I am a professor in the Department of Public Health Sciences at the Medical University of South Carolina. I am also the Associate Director of Population Science and Community Outreach and Engagement at the Medical University of South Carolina Hollings Cancer Center in Charleston, South Carolina, in the United States. Greetings to all of the participants in the 4th World Congress on Pediatrics and Neonatology 2023. The title of my presentation today is evaluating the first 2 years of an HPV vaccination van program in South Carolina. These are the co-authors who have contributed to this work. Many of you are already familiar with this information, but I thought I would start with a bit of background. So the human papillomavirus, which is known as HPV, is the most common sexually transmitted infection in the United States. And as many of you are aware, it spreads through intimate skin-to-skin contact as well as sexual contact. This is a molecular view of the HPV virus. Most of the low-risk HPV types do not cause symptoms, and they actually disappear because the body builds immunity to the virus. However, these low HPV types have no association with cancer, but they can lead to genital warts. Unfortunately, in the United States, every year, approximately 47,199 HPV-associated cancers are diagnosed. And most of them, 37,000, are estimated to be directly attributable to HPV infection. In South Carolina alone, we have more than 580 new diagnosed cases of HPV-related cancers every year. Approximately 170 women are diagnosed with cervical cancer every year in South Carolina, and 75 women annually die from cervical cancer here in South Carolina. What we know is that the high-risk HPV types 16 and 18 are the HPV types that are linked to 6 different types of cancer, including cancer of the vagina, penis, vulva, anus, and back of the throat. You might wonder about the sociodemographic characteristics of South Carolina, given these HPV-related cancer death rates. So here in this table, you can see South Carolina data on the right compared with data from the United States on the left. So we're fairly evenly divided between men and women in South Carolina compared to as is the US. What makes South Carolina unique is that 27% of our population consists of Black Americans. And so that's very different from the US and from many other states in the US. We have a small but growing Latine or Hispanic population, which has more than doubled in South Carolina in the last 20 years. And unfortunately, South Carolina is a relatively poor state. Our median household income is nearly $10,000 lower than the median household income of the United States, and we have a lower per capita income as well. We also have a higher percentage of our population in South Carolina living below the poverty level. Much of our state is rural. We have 75% of the 46 counties in our state include areas that are designated as rural, and 13% of the population is uninsured. We have a very large veteran population. We have the second fastest growing veteran population in the United States. And we have a unique population here in South Carolina called the Sea Island population. This is the least genetically admixed group of Black people with European Americans in the United States. Unfortunately, back in 2016, the HPV vaccination rates in South Carolina were the lowest in the United States. South Carolina ranked dead last in HPV vaccination rates in the entire United States. By 2021, I'm pleased to report that the rates of HPV vaccination in South Carolina, as shown by the gray line, had actually surpassed those of the United States in terms of first dose vaccinations. And here again, when we look at up-to-date HPV vaccination coverage in South Carolina, as shown by the gray line, versus the United States, as shown by the blue line, you can see again we were dead last in the United States in 2016, and by 2021, we had reached the US rate of up-to-date HPV vaccination coverage. I did want to point out that the US rate is significantly lower than where it should be. HPV vaccines are not required vaccines in the United States. And so you can see that even though South Carolina is now on par with the US HPV vaccination rates in terms of up-to-date coverage, both are still significantly lower than 100% coverage for the populations. So I'd like to describe the methods that we used in our study, in our program. We have an HPV vaccination van program that started 2 years ago in October of 2021. Our program includes a program director, myself, a medical director, Dr. Jimmy Roberts, a program manager, Ms. Melanie Slan, a scheduler, health educator, Ms. Joan McLaurin, and a pediatric nurse, Ms. Mina Platt. Our team works closely with community leaders, and we focus primarily on rural and medically underserved regions of South Carolina. We work closely with the director of the South Carolina Department of Health and Environmental Control Childhood Immunization Program, or CHIP, and the director linked us with nurses at each of the schools in the counties in South Carolina. So most of our HPV vaccination clinics are held in collaboration with schools in our state. We have regular meetings with our program staff and community leaders so that we can help to plan the clinics in the leaders' communities. We held our first school-based HPV vaccination clinic in the Cherokee County School District of South Carolina. They're located in the northwest corner of the state. At the time, Cherokee County had the lowest HPV vaccination rates in South Carolina. And so that's why we started there. We worked with community leaders and they asked us whether we would be willing to do a virtual town hall meeting that was from 6 to 7 p.m. for parents, other family members, and the students and teachers and faculty of the school district. We followed the school's lead and absolutely agreed to do the town hall meeting. It was wonderful. The first, we worked with the community members to put the agenda together. And so the first speaker was a high school science teacher from the school district who had been diagnosed with a high-risk HPV type many years ago before a vaccine was available. And she talked about the struggles that she's had and some of the invasive procedures that she's had to undergo and how she wishes there had been a vaccine available when she needed it. The second speaker was her son, CJ. He's 14 years old, and he talked about his decision-making process around getting the vaccine. In the 2 days after we showed this virtual town hall meeting on social media, we showed it live, 811 people had viewed the meeting, and more than 1,200 people have now seen the video. We offer the video to the other school districts that we work with. Some of them choose to do their own town hall meetings, and many of them have chosen to use this one. So this is just a screenshot of Ms. Christina Cody, the science teacher, who was diagnosed with a high-risk HPV type many years ago, and her 14-year-old son, CJ. And as you can see, he's saying that at the time he was reading a book called The Immortal Life of Henrietta Lacks. And he said he was thinking to himself that if HPV is that bad, then he needs to do something to help prevent it in himself and his partner. So he really spoke some words of wisdom that really resonated with every single audience that has viewed this video. Turning to our analytical methods, we have evaluated the sociodemographic characteristics of the participants in our HPV vaccination van program overall and by vaccination status. So Our state health department, when we were just starting out, asked us whether we would be willing to administer other childhood immunizations as well, and we said absolutely. We also have used descriptive statistics in terms of number, percentages, means, standard deviations, and we used categorical variables. We've analyzed the categorical variables using chi-square tests, and Fisher's exact test were used when the cell counts were less than 5. We've used the SPSS version 28.0.1 for the analyses. So turning to the results, you can see that we use geospatial analyses and data visualization tools to help guide where our HPV vaccination van goes in the state. So in the map on the right, the blue areas represent urban areas and the red areas represent rural areas. The lighter the colors, the less access the people in these areas have to the HPV vaccine. And so you can see that when if you overlay the 28 counties in South Carolina where the HPV vaccination van program participants live on top of the access map, you can see that we've done a pretty good job so far of tracking where our mobile HPV health clinics are offered, HPV vaccination health clinics are offered with the areas of the state with the lowest access to the HPV vaccine. Ultimately, our goal is to reach the entire state with our HPV vaccination van program, but we have focused on these underserved regions. So at the time we had analyzed the data, we had provided vaccinations to 825 people. As you can see, the majority of them are children. And I should explain that working with our state health department, we receive our vaccines for free from the state's Vaccines for Children program. This is a program funded by the Centers for Disease Control and Prevention that provides health departments with vaccines for children who are ages 18 and under, who are uninsured or are on Medicaid, or in other ways don't have private insurance coverage. And so that program focuses on children ages 9 to 18. And so that's why you can see the majority of the people that we vaccinated are in that age group. You can see that most of the participants have been Black or white or Hispanic Latine. The majority of our participants have publicly funded Medicaid insurance or no insurance at all. So this is just evidence that we are reaching the rural and medically underserved populations in our state. We have taken the van to a total of 24 counties, but our participants have come from 28 counties, meaning that some participants have gone to other counties to get the vaccine. And that just really highlights the need. So I'd like to spend a few minutes talking about our conclusions. So to date, our program has been offered in 24 counties of South Carolina, but we have reached residents of 28 counties in South Carolina. We have strategically chosen elementary, middle, and high school campuses as vaccine locations because we can reach children ages 9 to 18 years old through that approach. Most of our participants are insured by Medicaid, and that shows that we're reaching population residents who have lower financial resources. It also helps to reassure our rural pediatric colleagues that we're not taking their patients, because most of the private practices are not seeking Medicaid funded or uninsured pediatric patients. We saw that even though we faced some challenges implementing the program during the COVID-19 pandemic, the program seems to be successful in establishing partnerships with school districts and other organizations in South Carolina. And we now receive calls from school districts asking for the program. And I'd like to highlight the fact that we have recently established a partnership with the Perinatal Awareness for Successful Outcomes Group, or PASOS, in South Carolina. This is an organization that works primarily with the Hispanic Latina population in South Carolina, and they use a community health worker promotor model to reach the residents. We have also been contacted by school districts because some of their students have received letters asking them not to return to school until they get vaccinated. So there are a number of students who are outside of the childhood immunization vaccination window. And so we are very excited to be contacted by the schools, and we're bundling the HPV vaccination in with those other state required vaccinations such as Tdap and MMR. We have administered pre-test and post-test surveys to the parents of the vaccine eligible children to assess the parents' knowledge, attitudes, and beliefs about the HPV vaccine and their intention to have their children vaccinated. And we are going to analyze the study data, and we are planning a manuscript submission in March of 2024. So we're happy that our program serves as a model for mobile HPV vaccination programs for rural and medically underserved children to reduce their cancer risk. This is a picture of our mobile unit, and you can see our team here. So we're really excited. Ms. Melanie Slan was largely responsible for having this unit built during the pandemic. So that was a tremendous benefit to our current health system in South Carolina. I wanted to take a minute to acknowledge our funding sources. And thank you so much for your time and attention. And I'm happy to take any questions that you may have. Thank you.